Welcome to part 1 of our videos on physical activity and cardiovascular-related disease. In this video, we'll be looking at the role of physical activity in the prevention and management of several diseases, including ischemic heart disease, heart failure, peripheral artery disease, and stroke. Cardiovascular disease accounts for 27% of the death in the UK and 50% of death worldwide. At least 11% of these deaths are thought to be preventable through lifestyle measures alone. The benefits of physical activity on cardiovascular risk is not a new concept and is one that many patients will already be familiar with. The first landmark study on this dates back to 1953, pioneered by Professor Jerry Morris. He compared the number of heart attacks which occurred in bus drivers with the number that occurred in bus conductors. The bus drivers were found to have the higher risk of cardiovascular disease. Despite a similar social class and demographic between the two groups, Professor Morris noted that the bus drivers were far less active than their conductor colleagues and hypothesized that this may be contributing to their increased risk. Since then, there's been a multitude of both epidemiological and interventional trials. Meta-analyses have found that regular exercise can decrease the chances of getting ischemic heart disease by around 25%. Clearly, there's a wide diversity in study design amongst the literature. One cohort study involving almost 45,000 men over 12 years divided participants into quintiles based on their physical activity levels. They found that the most active quintile, which did the equivalent of 1 hour of running a day, had a 42% reduction in the risk of ischemic heart disease and found a dose response between physical activity and decreased risk of disease. Even in patients with established cardiovascular disease, habitual physical activity can still reduce all-cause mortality by 25 to 30%. In fact, rather shockingly, one study found that exercise training sessions improve survival more than percutaneous coronary intervention, or PCI, which includes procedures such as artery stenting, in patients with stable coronary artery disease, and was also far cheaper to achieve. Other benefits include around an 18% reduction in hospital admissions and an improvement in quality of life. Consequently, NICE recommends cardiac rehabilitation for all patients with heart disease, as it is a safe and effective way of encouraging patients to be more active. This can be even started within 10 days of a major cardiac event. Despite all the benefits attributed to physical activity for patients with heart disease, unfortunately, the uptake of cardiac rehabilitation is low in the UK at around 51%. Consequently, reasons for not participating in cardiac rehabilitation should be explored with the individual so that all of our patients are more likely to live longer, happier, and healthy lives. Physical activity can also improve the lives for patients with heart failure. Understandably, patients with heart failure may be cautious or even fearful of undertaking physical activity, as it may exacerbate their symptoms such as breathlessness. However, exercise has been shown to be safe for patients with stable heart failure, or classes 1 to 3 in the New York Heart Association classification, a widely used and well-known classification system. Meta-analysis shows that exercise can lead to an improvement in fitness level, functional ability, and quality of life, and a significant reduction in hospital admissions. Furthermore, although research is inconclusive, exercising for over 12 months may carry an additional reduction in mortality risk. Consequently, all patients with chronic stable heart failure should be offered exercise rehabilitation according to NICE. Peripheral artery disease is a common condition in which arterial blood supply becomes restricted, often in the lower limbs, due to atherosclerosis. This can cause symptoms such as pain, known as intermittent claudication, ulcers, skin changes, and in more severe cases, critical limb ischemia requiring endovascular intervention, surgery, or even amputation. Peripheral artery disease has a similar pathophysiology to ischemic heart disease and ischemic stroke, and therefore the conditions are highly associated, with 65% also having clinically relevant cerebral or coronary artery disease. Physical activity has numerous benefits, including improvements in walking distance and speed and quality of life, as well as decreased amputations, infections, pain, and mortality risk. This is particularly significant as the disease responds particularly poorly to pharmacotherapy. Patients should be encouraged to exercise to the point of maximal pain, and this should be done in a supervised and safe manner. Physical activity greatly reduces important stroke risk factors such as hypertension, type 2 diabetes, and hyperlipidemia. It also reduces stroke risk independently to these factors, contributing to an overall reduction in stroke risk by 20 to 35%. Furthermore, this reduction is dose dependent, meaning that the more activity an individual undertakes, the lower the risk of stroke. For those that have had a stroke, exercise has been shown to be more effective at reducing mortality compared to anticoagulants and antiplatelets, which have not been shown to affect all-cause mortality. Exercise can also help to reduce the disability that strokes can cause. A patient's limitation in physical activity is often exacerbated by deconditioning due to a lower exercise tolerance and reduced function. Exercise can improve quality of life and self-confidence, as well as tolerance for activities of daily living that can break this cycle. Resistance training also plays a role here through improved daily functioning. Thanks for watching. To hear more about why physical activity improves cardiovascular-related disease risk, please continue watching Part 2.